Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome back to another episode of the Unreal Results podcast. I don't even know what I don't know what the last episode was in terms of like what I said in the intro about where life was at. Because since I last had an episode, things got crazy. I ended up moving just 3.5 miles away from where I live in San Diego to the beach. I now live on Coronado Island. I am 2 blocks from the beach. I can see the ocean from my front door. It is absolutely amazing. I've lived in San Diego for almost 9 years now, and I've always wanted to live close to the beach. And I've basically regularly looked in the different areas that I enjoy for these 9 years, and always looking for something that is like in my price range. That's a really difficult challenge because things are very expensive here. And then also a good size, nice, doesn't feel like a freaking college apartment. And yeah, it just has good vibes. And preferably less like an apartment. However, I am in an apartment now. Whereas before I was in like a little bungalow. But it is like kind of old school apartment, not very many units. Really wonderful. Wonderfully taken care of by the people who own it. So really checked all the boxes. I was not planning to move, like I said, but I always keep an eye on things, and I happened to come across this place on Zillow because I had come across another place driving to the beach for my morning beach walk, and I wasn't even interested in that place. I was just actually curious what the rent was for the location and for the type of house. It was like a little craftsman home. And then like once you look at one thing on Zillow, then Zillow starts emailing you, like pinging you with like similar price points, similar areas of town, that kind of thing. So that's how I found out about this place. I got a Zillow about it, and the price, I was like, wow, that's a good price for that area. And then I looked at the area. I'm like, that's a really good price for the area. And then one day on a beach walk, I decided to drive by it and check it out because I was like, it's got to be a dump. Nope, it was not. I just like checked by the outside, and I was like, oh, that's pretty cool. Like, and I thought in my head, well, if I was interested in moving, I might look at it, but like, I don't want to move. And literally, I got back to my house, and within like an hour or two, my current landlord at the time had he called me and was just like, hey, just gauging where you're at. I know you're always looking for somewhere closer to the beach, and there's a possibility that one of our family members is moving back in the country and wants to rent your house. And he's like, we're not evicting you. We love having you. But he's like, I know you're always kind of like looking. And he's like, so just wanted to touch base with you and gauge your interest. And I was like, well, isn't that serendipitous? Thank you, universe. And I took that as a sign, and I reached out to this apartment, and I was like, hey, I'd like to take a look. And I looked the next day, and it was amazing. And to do my due diligence, I looked at some other ones in the area in similar price ranges, and some even more expensive. And this was still the best of all of them. Even the more expensive one, this was still like by far the best. And so I was like, am I really going to do this? And I was like, yeah, fuck it. So I applied, and then I got it. And then you have to sign a lease within a week of applying and getting approval. So I signed a lease, called my landlord, and I was like, yeah, I found something. So it was way faster than either of us was anticipating. And then also, like, not the most ideal timing in the world, because I was out of town at the Fascia Research Congress in New Orleans the second week of August. And then September always starts my fall launch for the fall cohort of the LTAP Level 1. So that just requires a ton of behind the scenes work from email marketing and social media and ads and linking email automations and enrollments and all this stuff that me and my team work on. And so it's just a big work time. Plus, it's the start of football season, so the start of my football travel for my athletes. I have another athlete that wanted me to travel with them. And then I have like 6 Navy SEAL candidate clients right now. 4 of them, which are currently going through first phase of BUD. So they're kind of very needy right now in the best way. Like, I love working with them, but it's just like, I have a lot on my plate. And then my family came down for Labor Day weekend and just... So needless to say, between that unexpected move and then my office and computer and like podcasting stuff being in a shambles, I just literally didn't have time to do anything. And so here we are. I might have even told that story on the previous podcast. I don't even remember. I do owe everyone a podcast episode recapping the Fascia Research Congress and my experience, what I learned, my takeaway, that, etc. And I still want to do that. I just haven't been able to sit down and like go back through my notes and really like sit with my thoughts and like really focus on what my takeaways have been, just because I've been so busy. So don't worry, that is in the pipeline. But I did want to sit down and just get back in the habit of recording these podcast episodes because, yeah, we're hitting the ground running. It's fall. If you're on the wait list for the online LTAP Level 1 course, we are currently in the waitlist pre-sale as I record this podcast. Whether the podcast will come out during it or not, have no idea. But hopefully you enroll if you're interested. There is a lot of bonuses I'm providing this fall cohort, so super pumped for that. And then, as always, whenever I launch the online LTAP Level 1 course, I also do the free version of the Missing Link course. And that's coming up the end of September. I should be opening the doors to enroll for that within the next week. So keep an eye out for that. I will definitely give an announcement on the podcast when it's time. So what I wanted to talk about today is a question I got in the Facebook group. So I have a Facebook group community for people who have gone through the LTAP Level 1 or the mentorship program. And it's a great community. It's about 350 people right now. So it's not everybody that's gone through the course, but quite a few. And it's just a great resource for like, tapping into the hive. And one of the questions from Deborah in it this week, I was like, you know what, I should share this on the podcast because it was a great question. She asked, she said, curious if anyone has experience working with a client 2 to 3 times a week, noticing quicker results versus spacing the sessions out. She's like, I'm wondering how to guide people when scheduling their appointments. And this is a great question. And it's something we talk about a lot when you're learning the LTAP. And actually, I talked about it a little bit on this last podcast, one of the last podcast episodes, which I'll have Joe link in the show notes, about the kind of like the interplay between being precise and specific with your assessment and treatment, and like what kind of results that gets you. And basically, what I talk about is the beauty of the LTAP is it gives you a way to have a more precise assessment. And so you can get away with having less precise of a treatment and having good results, really good results, versus when you don't have a precise assessment. If your assessment's fairly general, then it doesn't matter kind of how precise or general your treatment is. It doesn't, it's hit or miss. So with the LTAP being a more precise assessment, it allows you to have a baseline of good results with general treatment. And then as you can get more specific with your treatment, more precise with your treatment, you'll have an even greater response or outcome of your results, and they will be more long lasting. And so when we talk about this, or when I get questions about this inside the courses, whether it's an in-person course or the online course, for me, oftentimes, because I have a lot of very precise treatment tools to pick from, a lot of the times the results are so good, and there's a little bit of a ripple effect where I have a good result the day of treatment, and then the next few days they continue to get better. That allows me to space out the visits, sometimes by like 3 weeks to a month, without really diminishing the return on the treatment session. And so that is, that's part of too the realization I had of the need to create the LTAP for other clinicians, because of this observation with my athletes, that I was noticing that as I implemented this osteopathic general listening and local listening as my assessment, which was the hands-on feeling way of listening to the body and letting the body guide me where to start, I started noticing that I didn't have to treat my athletes as often during the week. The things I was doing once for my travel clients on a Monday or Tuesday held until I was back the following week or the following 2 weeks. And it started to make me very curious about like the reason for that, because previous to that, previously when I did not have that skill, I would find that, like back in the day, I used to have to release somebody's hip flexor every day in order to give them the hip mobility they needed. And it was like, man, if you can't see me every day, you're kind of screwed. And now it's like I can do a more specific technique in the area of the body they wants, and then their hip opens right up, and I never have to release their hip flexor, and then it's good for a while. So with that said, it's always this kind of interplay on multiple things. So to answer her question, was this interplay on multiple things. How precise is my assessment? How precise is my treatment? And then also, you can't discount what are the goals? What do they want? What are their performance or training constraints? What are their life constraints? What are their financial constraints? What other services do you offer? So oftentimes too, for me, it's like, I'd say the majority of the time people are utilizing me to assess what's going on, to give them an idea of what's happening and how to fix something, or how to make themselves feel better, or like what to do about an injury. And then also relying on my manual therapy skills to make changes, and or me giving them a few exercises that are going to support whatever manual therapy treatments that we do. But then I also have the skill set that I can do exercises with people, right? I'm a strength and conditioning coach. Obviously exercises are a very important part of rehab, especially like post-surgical rehab, or like post-injury rehab where there's been some sort of immobilization or lack of training going on, where true strength is needed. But then also I'm trained in Pilates, so it's like, there's value in giving people movement and movement experiences. And that's when it comes down to the type of patient. A lot of times you'll hear me say with my athletes, like, I don't spend a lot of time doing movement and exercises with them when it's just maintenance, because they're already doing a ton of that. It's just sometimes, like, whether I want to or not, it's oftentimes not what they're coming to me for, and then also not what they really need to, like, move the dial with whatever their goals are. And so, but there are instances that I utilize those skills more. And then there is value in general maintenance manual therapy, in the sense that there's a huge value to regular self massage. And sometimes my athletes would rather have me work on them than do the self-massage themselves. And so that comes down sometimes to a financial constraint. Like, does somebody have the money to be paying me throughout the week to work on them more than once for something that they could be doing on their own? Versus, do I feel like they really need this multiple times a week? So there's, as with any answer to a question like this, it's not black and white. It's very gray and very dependent on a lot of different factors. And so I thought, I thought the best way to answer this in the Facebook group was to give an example of what clients I have right now and how I'm working with them. So you can kind of see where my thought process lies. And it's great too, because right now, as I said at the beginning of this episode, like, I have quite a lot of patients right now, which is a little bit abnormal for me, but I'm loving it. So it's actually really good because you get to see a good mix of sort of like what's going on. So I'm just going to, I have these right now, so I'm basically going to read them and kind of add on to it. So first patient I have, I actually haven't seen him in a while for travel constraint reasons, but also kind of given where he's at in his rehab, he doesn't necessarily need a whole lot anymore. So he's 5 months post-op knee chondroplasty. He's having some pain with return to training. Ideally, I'm seeing him every 3 weeks for about 1 to 3 days in a row of assessment and treatment. With that assessment and treatment, I'm doing the LTAP every day, so the body can guide me on where to start treatment and just like clear up and ensure that we have the best like dynamic alignment and mobility and nervous system, autonomic nervous system resilience, so that when we go do manual therapy or exercises, he's going to get the most out of it. It's going to stick. And then during those treatment sessions too, I'm giving him a little bit of guidance on like changing his exercises as needed, checking in with his strength program. So I'd like to go with him to the gym to see how things are looking. He's also giving me videos fairly regularly. And then, all of this like 3-week check-in also gives me an opportunity to give him a little bit more notes for his providers that he sees weekly for more general work. Then I have an athlete that I just discharged. She was a post-op patient as well, fracture dislocation surgery of her ankle. And when I was working with her, our constraint was she was moving away to college at us, like middle of August. And so we knew we were limited on time together. And so I would see her, but also there was a little bit of a financial constraint. She was cash pay, and, that adds up very quickly, especially in a post-op world. She's fairly compliant and working out on her own. She's 18, so she has a little bit more wiggle room of what she can get away with from a load and movement standpoint. So it's like I didn't feel like I needed to be with her for her exercises all the time. We basically picked certain exercises from her program with her treatment sessions so I could look at her movement patterns, give her any coaching cues. She's an athlete, right? So she picks them up really easily too. But for the most part, when we were working together these 2 times a week, it was do the LTAP, see where the body directed me. If there was a need to be directed somewhere, oftentimes she came in and there wasn't really, the body was like, yeah, do whatever you want. So then we would focus on manual therapy. I wanted to maintain a focus on manual therapy for her scar, for her lower leg as her strength came back, because also I knew when she was going to college, she wouldn't be getting a lot of manual therapy. It would be a little bit more exercise-based than anything else. And then we would do exercises too. And as we progressed through the summer, it started with and this is a normal transition that I often see with these post-op patients, is the body has a lot of layers to offer me in the LTAP, and a need for a little bit more manual therapy at first, and then things get better and things normalize and get balanced out, and then we can focus on exercises a little bit more too. So the next person is I'll organize these a little different. So the next person is one of my NFL athletes. He is just started in season, basically. Training camp just got over. So he has transitioned from the summer off season being maintenance every 3 weeks to now he's in season maintenance every 3 weeks. So I come in, I do the LTAP, I do a general listening, I see where his body is taking me, I ask him what's going on, what he'd like me to focus on. This is typically a manual therapy session. He likes just one treatment, even though, I can be there for more than one day. He's just like 1 time a week works. So I come in and it's, I consider it a little bit more of a tune-up, and then I communicate with his other manual-based provider who sees him 1 time per week as well. That other manual-based provider is actually someone who has gone through all of my education. So it's nice because we speak the same language and, we share after our appointments with each other what's going on. So then, let's see. All right. Everybody else on my list is going to be these Navy SEAL candidates that are either in their prep period before starting first phase of BUDS or currently in first phase of BUDS. And they have probably the most constraints on them because they have a financial constraint. They have a time constraint because they can't do treatment during the day. They have to be working, on base. So oftentimes they're limited on days of the week or times of day that they can see me. And then they also have constraints in terms of no matter what's going on in their body, they can't really take off training. And this means that if you're not familiar with this physical prep and BUDS part, or like first phase of BUDS, it's very physically demanding. They basically are constantly running all day long, doing exercises all day long, swimming, like doing underwater activities, swimming, running, lunging, push-ups, burpees, sit-ups, forward rolls, body carries, like literally all the things all day long. From a strict mileage standpoint, they're going to be averaging between probably during prep, I'd say 40 to 60, 70 miles per week. And then as first phase starts, that 70 miles per week increases to like 100, 150 miles per week. And then during Hell Week, it's going to be about 250 to 275 miles per week, which is freaking nuts. But those are the constraints we have. And so it's a little tough, but I'll go through these guys' things so you can kind of see where my thought process was. So one has, sorry, I was just reading. I was like, who is this? I don't even know who this 9th person is. Oh, professional athlete. So one is that's why I missed my other athlete. So I have one more professional athlete before I get into these buds guys who literally just sees me once a month for general maintenance. He's currently in season. He takes pretty good care of his body. He utilizes the athletic training staff, sports medicine staff on the teams he's with. But he likes to see me one time per month if possible, given his schedule and where he is at from a location standpoint as well. Okay, back to the buds guys. So I got one guy that is just general back kind of scoliosis type of pain and calf tightness. I see him one time per month as needed. He's basically really an as needed sort of guy. Like I see him, I use the LTAP, we focus on whatever's bothering him. I give him some self-care, answer any of his questions, and then he will reach out and reschedule with me. And it's been about one time per month since I met him. Another guy has hip pain. And then also just wants to see me for maintenance. Most of these guys, maintenance means also like calf massage, like just lower leg, foot health type of thing. I see him right now. He's currently in first phase, so he's at that highest amount of volume. So I'm seeing him 1 to 2 times per week. And then another one, hip flexor strain and acute hip flexor strain. Chronic shin splints. He's also at this highest volume of first phase. And I just started working with him, and last week saw him 3 times per week, and it would be great if I could see him at least 2 times per week, just given the acuteness of what's going on. And then also he's a new patient. So sometimes when it's a new patient, it takes me like some visits to get them to the level of maintenance. So sometimes it's nice to knock out those visits within the first 2 weeks to sort of like tune things up to a point where it's like, okay, we can maintain this now. But again, his main constraint is his schedule, not necessarily like I think seeing him more times since he has an acute hip flexor strain would be best, but we're limited on his schedule. Another guy with neck pain and an acute ankle sprain. He's also in this first phase, high volume, high amount of hours, limited time. So far he's a new patient too, but his things like changed very easily with the first treatment. So I think just seeing him 1 time per week and then giving him some like self-care things is more than adequate. Another one is he's in prep phase. He is actually 1 week, just about 1.5 weeks post-op knee meniscectomy surgery. I've seen him 2 times since surgery. Right, I think weekly for him is going to be fine just because he's starting rehab with the physical therapists. That's part of their program, which are exercise-based physical therapy for the most part. So I view my role with him as focusing on decreasing his swelling and helping his range of motion to facilitate these exercises being easy so he gets the most out of them. So 1 to 2 times per week. 1 to 2 times per week, especially in the beginning as he's more swollen, is great. And then he's doing the swelling reduction protocol on his own in the interim. And so far he's doing really well. And then the other guy, he is my, I'd say this is going to be an outlier, and you might hear what I do with him and you're like, what? He needs that much? But yes. He had bilateral severe shin splints, / I'm pretty sure some level of exertional deep posterior compartment syndrome. So when I was seeing him, I started seeing him probably like 12 weeks ago, and I needed to see him almost every day of the week for manual therapy because it was a challenge. Part of that challenge, though, is that he's within that constraint as we couldn't back off of his training. There wasn't a time that we could stop having him run or stop having him work out because of the nature of the program he's in, and also the intention of him starting with his class, starting first phase with his class. There was just like no time to take time off. And so we were trying to rehab this issue that he had had for over a year with nobody being able to help him with all of these constraints, and we were making progress, but it was just one of those things that it was clear that it was only going to continue to make progress if we stayed on top of it daily. As his schedule got busier as they entered first phase, now I can only see him 3 to 4 times a week, and he's doing pretty good. We've got the shin splints under control, but now that's turning into some other little niggles that we're staying on top of, as well as staying on top of the shin splints because of his history to make sure they don't come back. And so I actually see the most out of any of my patients ever in this scenario. Again, in a perfect world where we could have ramped up his training, cut back on training, I don't think he would have needed daily treatment because we could have managed his load better, but that was just not the option. So I'll give you a little blurb of what I said. So I said, despite them all having different needs, niggles, soft tissue injury, post-surgery, or maintenance, the process for me remains the same. I start with the LTAP and or listening and let the body tell me where to start and how to proceed, right? It's that concept of every round of the LTAP gives me a different layer, different sequence. So I explain it as like there's a certain combination lock code that I'm trying to figure out. I can't just know the 5 areas that I need to treat. I need to know the sequence of them, and that's what's really going to help with the results. So I continue and I go on and say, even when the main focus is exercises and strengthening, I start with the LTAP. This allows me to ensure that I have the most optimal environment to proceed, which means less fighting with the body and more ease. This looks like less need for cognitive cues and a lot of mobility work or concentrating on firing certain muscles. So, you heard me speak about that with that collegiate athlete with the ankle fracture dislocation post-op. Is even as we transitioned into more exercises, we always started the session with an assessment to be like, because to me, I'm like, I don't want to just jump into exercises if your body is in this protection pattern that is going to limit us or inhibit us from getting the most out of the exercise. So I want to make sure that we're always like starting by peeling off whatever protection layer somebody has, because this is going to set us up for the most success. So then someone asked me the difference between the person with the acute hip pain, hip strain, and then the other one with the ankle sprain, acute ankle sprain. And I said the difference here is more of a severity thing. The guy with the hip strain could barely walk. The guy with the ankle sprain was swollen but functioning totally fine. And so it was like, that's what dictated that I wanted to see the person with the acute hip flexor strain more often than the person with the acute ankle sprain. So that's definitely part of it. And then I said it's a little bit of preference and a little bit of severity and just how I feel about the entire assessment and session. So throughout the session, the body is like, oh, treat here. And then I'm reevaluating all the orthopedic stuff. So I'm getting to see how this orthopedic picture is changing. And that starts to inform too of like, because at the end of the day, when somebody comes to you with like knee pain, hip pain, neck pain, whatever it is, your job is to create an index of suspicion on like what is causing it and what is like aggravating it or what hurt it in the first place. And so as I'm treating all these different spots and as I'm reassessing and seeing how it changed, I'm taking that into consideration with the sort of index of suspicion of what's going on. And then at the end of treatment, I'm deciding, like, based on my index of suspicion and how you responded to treatment, is this something that needs like continual care this week, or can you wait a week? And oftentimes with most of my patients, what I tell them is, let's not schedule your next appointment until you text me in the next 72 hours and let me know how you feel. Because I want to know, like, did we make the shift that we thought we made the shift today? Like, today I know we made a change, but tomorrow did it go right back to where it started? Or is it continuing to get better? And sometimes when I know that how they're done at 24 or 48 hours out, then it's easier for me to determine when to bring them back. So yeah, and then I think that's sort of the gist of like what I shared via that post in the Facebook group. But I thought it was just a good picture of like, it's not black and white. It's not like, oh, this person comes in for hip pain and I'm going to see him one time a week for 5 weeks. Like, that's not how it is. Like, at the end of the day, whenever anybody comes and sees me, I'm still like in the 1 to 3 visits guaranteeing results. But a lot of times they want to see me more than 3 visits because it always turns into maintenance, or it always turns into them thinking like, man, if I saw you regularly, maybe this would prevent things from feeling like crap. So if I am going to see them more than once, I'm going to probably, especially if it's a new patient, I'm like, okay, 1 to 3 visits. I know I can figure this out. Those 1 to 3 visits are probably going to be within 2 weeks of each other. Probably not all 3 in 1 week, but definitely 3 in 2 weeks. I still do exercises. I still give exercises often for like self-care, home exercise program thing. It's just not always going to be the bulk of my treatment. It can be. I'd say if I was going to put myself in a box, the majority of the time, like I said at the beginning of the podcast, is like I tend to do more manual therapy than anything. But that often is just like what the person's coming in for and what they're already doing. I work with a lot of athletes who are already exercising. If you work with general population people who are not moving their bodies at all, they're probably going to need more movement and exercise instruction. My approach changes when it's not an athlete. Do I still do quite a bit of manual therapy? Yes, but is it the only thing I'm doing? No, because movement heals and people need to get stronger, period. So, I guess the overarching theme to this too is like permission to see what works for you and your patient population and be curious. Try once a week, try twice a week, try 3 times a week and see what happens. And then adjust as needed. And you'll start to notice patterns based on results of the assessment and treatment, based on certain types of pathologies, certain types of people, etc. And then at the end of the day, you're still asking the person what they want. If somebody comes to me and they're like, Anna, I want to see you 3 times a week regardless, am I going to tell them no? No, probably not. And the only time I'm going to tell them no if I just don't have the bandwidth for that. But if that's what they want and they want to pay for that and like they're finding value in it, who am I to say that they don't need that? And so I'm not going to change what I do though. Still going to start with the LTAP every time. Still going to follow what the body wants. And then if they're coming for me for manual therapy, then great. If they're coming for me for exercises, great. If they're like coming for me just to be like, Anna, I trust your knowledge and do whatever you think is appropriate, then I'll probably do a mix. So I know it's not like the best answer because it's not like, oh, just plan to be telling your patients from here on out that you're only going to see them twice a week or 3 times a week or once a week or once a month, whatever it is. But it's like there's nuance to it because it depends on the person who walks through the door, depends on your schedule, depends on the constraints of their life, their finances, their team or program they're in, all of the things. So hopefully that's helpful for everyone. And thanks for the question, Deborah.